But so we will discuss what is the evidence for hypothermia in mild HIE. And we all know today that cooling to 33.5 degrees for 72 hours within 6 hours of birth is safe and it's effective for moderate severe HIE in infants at 36 weeks or above. And it reduces the risk of death or and the combined outcome, deaths or severe disability, both at toddler age and in childhood. And that is known from those famous studies, CoolCap, Toby, the Australian IC, and etc. And I didn't think I would go through those studies. But here is the first question then. So if you have a term-born baby and there was some serious event during delivery, the baby came out, you got a pH, the first umbilical pH at 6.95 and a base deficit of -17. And you have, this baby is irritable and have exaggerated reflexes at 6 hours, but you have a normal AEG. Would you say this is a mild HIE? It seems to be a little bit controversial whether it's mild or not, but the majority thinks it's a mild HIE. So next question, you have a term-born baby, same thing, sentinel event, same blood gases. Sorry, it's the same baby, but would you cool this baby? So the baby is irritable. About 70% thought it was a mild HIE, and about 70% says they wouldn't cool, and 30% would. Yes. Interesting. Still changing a bit. More cooling, 35%. Wow. Okay, here's another baby. Born at term, sentinel event, same blood gases, but this one is not hyper, but hypotonic, with a weak Moro, a weak suck, but otherwise normal at 6 hours. Normal AEG. Does this baby have a mild HIE? This was more difficult. We have almost 50-50. Yeah. So the staging is really, really difficult here. Still changing. Okay, and the same baby again. Would you cool this baby? 50% said it was mild HIE. Wow. A little more than 50% would cool the baby. So 73% yes. Still thinking about it? Yeah. Yeah, very interesting. So let's see if we will change our minds after putting up the evidence. I don't know. Okay, so I think you're all well aware of this old chart from Sarnat and Sarnat, published in the 70s. HIE is, as you all know, based on the A criteria with APGAR scores at 10 minutes, at 5 or less than 5, or having ventilation at 10 minutes, or having a pH less than 7, or base deficit more than 15. But then these are the B criteria. This was intended to be used over the first week of life, because at that time we didn't have hypothermia. But today we need to use it before 6 hours of life, because we want to decide whether or not to cool the babies. And as you know, there's the level of consciousness, the tone, and the reflexes, the autonomic function, and in the SARNet score, it's the presence of seizures and also EEG findings. And according to the original score, it should disappear within 24 hours if you have a mild stage, a mild HIE. So I think it's commonly, mild HIE is commonly thought of like this: extreme irritability, feeding problems, lots of crying or sleeping a lot, with abnormal reflexes and stiff muscles. And the difficulties are, as you all know, that this might progress after 6 hours. They might be mild at first and then become moderate, and all sorts of biological differences. So I think that's where we are stuck. So this, I think, is the agenda for today. I would go through how common it is thought to be, what maternal and neonatal factors are associated, and how does it affect the long-term brain development, how many has been cooled already today, because there's a lot of misclassification, as we know, in the cooling studies. What are the risks and how does it affect the parent-infant attachment? And what is really known about the effects? And what ongoing studies do we have? How common is it? Well, I don't think we really know, because my guess is that many are not diagnosed or not brought to the NICU. But in the high income setting, we all know that a commonly cited figure is 1.5 to 3 per thousand have HIE. And in the low income setting, up to 30 per thousand. And the best guess is that perhaps 50% of them have a mild HIE, but we don't really know. And this is a Swedish study, again, the Swedish National Birth Registry that covers 99% of all births, and combined with the diagnosis registry. So the authors looked through all births between 2009 and 15, and that was 710,000 births. And they excluded all the babies with malformations and all the ones with any diagnosis of moderate to severe HIE, and any doublets. And then they also excluded the ones who had been treated with hypothermia but no HIE diagnosis. So they ended up with a study cohort of 505,000 babies. Out of them, 414 had a diagnosis of mild HIE. And there were a few differences in maternal risk factors. There were more primipara in the mild HIE group. There were more mothers with diabetes. And there were more mothers from other countries. And neonatal risk factors were not surprising. There were more obstetric emergencies, more instrumental deliveries, higher incidence of low Apgar scores at 5 minutes, and more large for date and small for gestational age babies. So it's just exactly what we would expect. How does this affect long-term brain development? And the short answer is we don't know, but there has come up a lot of studies recently showing that actually this category of babies have a lot of problems in the long run. And in this Swedish national cohort study with then 414 mild HIE, there was a higher risk for both death, 19 times higher, a higher risk for CP, 20 times higher, and also for epilepsy. And here is a systematic review from Deirdre Murray's group, looking into 341 cases of mild HIE, and they reported abnormal outcomes in 25% of these. infants. So imaging can tell us maybe something about the mechanisms. And there are a number of small imaging studies, and on MRI, there is brain damage in perhaps more than 50% of infants with mild HIE. And it's interesting to note, I'll show you in a minute, but you know, the hallmark of moderate to severe HIE is more basal ganglia, thalamic lesions, but here you more often have watershed lesions in the frontal lobe. Here a study from Yvonne Wu's group in UCSF of babies with mild HIE, 142 babies. And they found injury in more than 50%, as you see, but there were really no differences when it came to gestational age, where if they were outborn or not, pH, APGAR scores, if they were cooled or not, because they cooled some of these, if they had sentinel events or not. So it was really difficult to know without doing imaging whether they would have brain damage or not. And the images that they report in this study are then here to the left. We have this diffusion weighted imaging, and you see, as always, the posterior limb of the internal capsule is affected, and the thalamic nuclei. And here's the same thing on the T2 weighted imaging. So they also saw some cases with deep gray matter injuries, but also this watershed infarction here on the ADC map. And it was really the most common type of injury in this material, the watershed infarction, that was found in 50% of the children that got no hypothermia and 18% in those that got hypothermia. Watershed infarction has been linked to a more subacute injury, so maybe it did not happen really during delivery, but earlier. There's some evidence that maybe cooling is not as effective in this type of lesion. It's also the lesion that is more associated with cognitive deficits. Here again, the watershed. So we see it's quite there is no real differentiation between gray and white matter in the frontal lobe. So how many infants with mild HIE have already been cooled? And here is a paper from England and Wales population with 3,500 infants admitted to NICUs with mild HIE, and a third of them were actually cooled. So it happens a lot, and we see that when we have our poll as well. And here is another review of a lot of hypothermia studies where actually babies with mild HIE happen to be included. And out of those 2,700 infants included in those 12 studies, 22% had actually a mild HIE. So what are the risks with cooling babies with mild HIE then? This is from the Canadian network with quite a large sample, almost 700 in the standard care and 390 in the hypothermia group. And they report longer times in the hospital, more opioids in the hypothermia group, longer duration of respiratory support, longer intubation times, gavage feeding, pulmonary hypertension, renal failure, disseminated intravascular coagulation, and hepatic and cardiac dysfunction. but not more seizures. So all of these side effects that are known to us when we treat hypothermia in moderate to severe babies are also very common in the mild cases. And here is another one from California, also quite a big sample showing that they had longer times on the ventilator and they were longer intubated. It was a retrospective cohort. So there are clearly a lot of side effects cooling these babies. And one important thing is also how it affects the parent-infant attachment. And there's a study from Southampton on this, and I took this from Uppsala because it was a nice image. It's a qualitative study, but this mother she says that I wept so many tears of joy just to get hold your son for the first time. So we need to be constantly aware of that the parents really want to be actively involved even when they are on hypothermia. And we need to also be very proactive to let them be close to their children during that time and afterwards. So finally, to the real question, is it effective for brain lesions? And there are 2 systematic studies, a very small number of babies included here. You can see there's a total 45 in this study from Murray's group, where there is really no significant effect on outcomes at more than 18 months, neurodevelopmental outcomes. And it was clearly not powered to look at that. And here's the other systematic review from Sita Shankaran's group, and also a small number of babies, 57, with absolutely no effect of either cooling or usual care. So underpowered studies. Here is non-randomized cohort study on using MR as well. So hypothermia was initiated within 6 hours in mild hypothermic cases, and then they looked at biomarkers for MR. And in this, it's a very small study, no cooling 15 babies, 72 hours of cooling 32 babies. And there was really not many changes in the background characteristics, but a longer hospital stay again in the cooled babies, of course. And they looked at the brain metabolites, and you may know that it's not only the brain lesion, but also the MRS spectroscopy data that is predictive of outcomes in HIE. And in this case, they looked at N-acetyl aspartate versus choline ratio and versus creatinine ratio, and found that the cooled group was actually significantly preserved. I mean, higher rates of this quotient means preserved neurons. So it looked a little bit better in this small cooled group. Again, very small groups, and these are the Bailey outcomes, and there were no clear effects on the Bailey outcomes, but again, an underpowered study. So more studies are needed, of course, and I checked clinicaltrials.gov for that, and what is going on now is the Cool Prime study. But it's an observational study with Lina Shalak as a PI, and they are aiming at recruiting 460 participants to hypothermia or no cooling based on center practices. And it's recruiting right now, but it's good that they have a primary outcome with the Bailey scales. Bailey 4 scales is what is present type of Bailey. And here is another ongoing study, or not yet ongoing, perhaps not yet recruiting. It's from UCSF and Stanford, and it's called the TIME study. and it's an RCT, but very small with 68 participants and very short-term outcome, I think 12 to 14 months, including motor skills and adaptive and functional skills. We still hope for a really good RCT in this field. And I just wanted lastly to show you this study, a survey of clinical practice and opinion from 35 countries of hypothermia in mild HIE. So they got 480 responses from low and middle income countries, half of them, and from high income countries. And there were mostly responders from China and the US. And most of them were in public hospitals, and most of them were neonatologists. Here we see what they responded, that in the low and middle income countries, 25% had a routine practice of offering hypothermia for mild HIE, and 16% in the high income setting. And they got the same questions that you got in the beginning. The irritable baby here, 57% would like to cool it in the low and middle income setting, and 37% in the high income setting. And about 80% labeled this baby as a mild HIE. And the second baby that was hypotonic, about 30% would cool it in both settings, and about 55% would label it as a mild HIE. And about 50% in the low and middle income setting had a protocol for managing HIE. Some of them did initiate cooling a little bit later, also 40% up to 12 hours. It's interesting also to note that there were about 30% that used some adjunct education therapies like erythropoietin and magnesium sulfate and stem cells, actually. MR assessment was done in like 50% of, and neurodevelopmental follow-up. And I'm happy to see that almost 90% of the low and middle income setting and 75% of the high income setting had that. And they were very much willing to enroll in future really good RCTs. So I think, and this is cited from Seita Shankaran's paper also, that it's time for a good RCT in this field, because we cannot really say whether it's good or bad for mild HIE. And as we noted in the beginning, it's really difficult with the classification. So we need to work on the classification and define distinct criteria. And we could this time, perhaps AEG has got such a good spread, so maybe we could consider including AEG. We would use the same temperature and the same duration of hypothermia, and the reason for this, I haven't gone through it, but it's the animal experimental data that really has showed that it's not beneficial to cool any more less than 33.5 degrees, and not to cool any longer either. And it's important to do the right outcome measures, because what matters to families and children is really the long-term outcomes. And we all know it's difficult with the Bailey scale outcomes at 2 years. And so it should really be a 5-year assessment where you can measure IQ, etc. And it's important to have a good sample, so that we are not underpowered. We're constantly underpowered now. And then we have to just say that if it's not safe, if it's not effective, then we shouldn't offer treatment. But if we find it's safe and effective, then we should offer treatment. But we don't know today. Here is a mild HIE baby at day 2, recovering. in its natural place. Thank you for your attention.